Orthopedic surgeons always face one of the biggest challenges, one of the more nervous of all them. When somebody gets hit by a bullet, or when somebody gets run in the street, or falls off a building, then we have this pathology. We call them open fractures. So join me in this video so that you will know how to diagnose it, how to treat it, how long has it been here with us, with humanity. So follow along. Open fractures have been happening since the beginning of time, since the dawn of humanity. We can see in Egypt that they were already doing surgery on fractures while putting intramedullary nails, which we see on mummies. But the most interesting thing is that they studied the mummies and did some arthroscopy on those old mummies, and they found resin that was fixing the bone together, like the bone cement that we use, the polymethyl methacrylate. Well, these guys were using something made out of resin from plants, and it worked. So Egypt was more interesting than we know about when we're talking about open fractures. Then came the Greeks. The Greeks did things differently. Hippocrates was the first orthopedic surgeon. He had the Hippocratic move of putting his foot into the axilla and pulling on the arm of patients for fixing shoulders, putting back into the place. They used a lot of splinting. They were starting the dawn of the treatment of battle medicine. Okay, so then came the Romans and took all these from the Greeks, not that much from the Egyptians, and they started doing things like the Greeks. But they did a lot of more casting and fixing of the bone so that they were fractured during battle and they could keep fighting while having the arm involved in metal, making these casts or these splints with very heavy, but they could use them in battle and just survive the battles. Okay, it could be in a circus or just in the field in Germany, who knows. Well, time came and the Mid Ages arrived, so we see that the Arab medicine was the one that was really making different things differently. Europe was stuck in these dark ages with religion all over the place, so they were just doing some casting and some splinting, but not any surgical advancement was seen until the Renaissance, where in the Renaissance we see that there's a deeper study of anatomy and a new interest in making medicine different again. Then illustration came along and we see that new medical improvements start to appear in a faster way until the French Revolution, when we really see a change in social and medicine. So we're gonna see more battles, more people wounded, and then we get all the way into the present times. And in the 19th century, we see that medicine makes a giant leap forward. We see the appearance of hospitals, of inner care of patients. We start to see Samuel Weiss, who came out with the washing the hands and the asepsia. And then in the beginning of the 20th century, the new studies of Pasteur, Alexander Fleming, we get to see the bacteria. They start to study the microscopic world, and we have Elizabeth and the new beginning and dawn of the management of surgical fractures, like open fractures. So we're gonna talk about open fractures. A 24-year-old male patient driving his truck from his social service town back home suffers an overturn due to the excessive speed and he gets ejected. When picked up by the Red Cross, the femur was found exposed through the skin with a bloody wound of approximately 10 centimeters with road dust in it. So this is the case. And we know there's an exposed bone, but they're telling us that he has road dust in it. According to Gustilo Anderson, this fracture should be classified, or how is it classified? So here you have the different degrees in Gustilos. So we're gonna grade it at 3B. Okay. So Gustilo-Anderson is the right classification that it's in the classic literature for orthopedic surgeons, and we classify patients that have this kind of accident or situation where the first degree is a puncture less of 1 centimeter with less than 8 hours of evolution. That means that the patient is during this time frame where he has to get the medical attention. If he doesn't get the right medical attention during these 8 hours, then the open fracture becomes next degree, a 3A degree by Gustilo-Anderson classification. How these first degrees open fractures happen? Well, you're gonna have the bone in a straight line, and suddenly you're gonna have the zigging. That means that when it crashes, a piece of the bone makes this sharp point that touches the skin and comes back like a switchblade. It opens, and that makes a very small lesion. Okay, so that's the lesion that we're talking about. Second degree by Gustilo-Anderson, that means that it's greater than just 1 centimeter. That means that it's a bit bigger, or it can go all the way to 1 inch or maybe 2 inches, but that doesn't really matter. What matters is that the skin on top of the fracture covers the bone well enough so that you don't have any openings left. Okay, so if you have a good coverage of the skin, then it's a second degree. It doesn't matter really how big is it. What matters is that the skin makes a good coverage and it's treated in less than 8 hours of evolution. Okay, we call it a good coating. Then we have the third degree. The third degree is divided in 3 types, so it's 3 for 3. Okay, 3 divides in A, B, and C. The 3A is either a first degree or a second degree that were not taken care of in the first 8 hours after the accident, so that turns them immediately to this. The difference is that when we're talking about the outcome, we're gonna have a worse outcome when it's a 3A than a 2. Okay, then when we talk about guns, when you have somebody fire a gun on another person, then you're gonna see that slow bullets, and we call slow bullets like the guns that when they fire, the bullets travel at less than 300 meters per second. Okay, these are the 22 calibers, the 38 calibers that are usually in possession of civilians. So these bullets, when they enter the skin, they make this big sound cone, we call it. It pulls air from the outside into the body and it expands. So a 22 or a 38 caliber, they're gonna make small sound cones, but where this sound cone happens, anything that it's close to it, it's gonna get ripped, it's gonna get broken. So if we're talking about blood vessels, if we're talking about internal organs, they're gonna break. Same for the bones. So how much stress can a bone take with one of these guns? Well, it's gonna be less stress if you get shot by a high caliber. So low calibers, we put them into the 3A category. Okay, also small fractures or big fractures that have bad skin coating, automatically without taking care of the patient, or no time frame is referred here, you're gonna have a 3A classification just put right immediately. So we're gonna go to the next step. It's a 3B. The difference is that we don't talk about coating anymore. Here we're talking about pollution or contamination on your wound. This is going to happen with dust. It's going to happen with water that it's like dirty water on the road, or if the fracture happens in farms, according to literature. But the patient works, and he's gonna say he's not directly on the field. Maybe he's working in an office. Well, it doesn't matter. As long as it's a farm, we're gonna treat it as a 3B. Okay. This could be in a very weird situation where you have a high velocity bullet that goes through the patient but doesn't damage any blood vessels, which is kind of impossible. But well, I have to tell you this because it might be on any of your orthopedic surgery exams. So we call these open fractures contaminated. Okay, a 3C is going to be an open fracture with neurovascular damage. Okay, it doesn't matter the size, it doesn't matter the place. If you have neurovascular damage, it's a 3C. Okay, if it's a finger, if it's a femur, no matter. Okay, neurovascular damage is a 3C, and this might be a criteria for amputation. Okay, we're gonna talk about the criteria for amputation in 3Cs. It's the MES category. It's Mangled Extremity Severity Score. Okay, we're gonna see it after we talk about the treatment for these different open fractures. So we're gonna talk now about treatment. Treatment for type 1 open fractures. It's gonna be surgical lavage in the operating room. Okay, remember, surgical lavage must take place in the operating room so that we may have a sterile place where to work at. If you do this in the emergency room, well, you might do the technique, but the place it's not sterilized, and you have a high risk of putting something new on the infection on top of whatever the patient may have. So by protocol and law, it should happen in the operating room. Unless you're in a battlefield and you're a soldier and you're gonna just do it, okay, well, that's a different situation because you're trying to save the patient's life. Okay. Second, you have to give empiric antibiotics. These antibiotics have to be first generation cephalosporins. These antibiotics are going to take care of the gram-positive bacteria, which we have in 90% of the bone infections when we're talking about open fractures or inner fractures or whatever kind of infection happens in orthopedic surgery. We have positive gram-positive coccus. So we're gonna treat these with first generation cephalosporins until we have something brought from the lab that tells us that in a culture we have the specific bacteria, and they've done the test to check out the right antibiogram of these bacteria so that we know which antibiotic is specific for it. But these cultures may take up to 10 days. So we cannot wait for 10 days for these to come to us, because the patient might have this infection and it might just become osteomyelitis or septic disease. So always give empiric therapy. Second, third, it's going to be splinting. After the surgical lavage, you are not going to leave just the bone dancing around, because it's sharp and it may damage the tissues that are around the first lesion. So you might have blood vessels cut or maybe a nerve damage. You don't want that. So always plane it at least, or do the osteosynthesis in the first turn, but it has to be done with an external fixator. The reason is that no matter how good you feel you did that surgical lavage, you might have some microscopic residues on the bone, and if you fix it with metal on top of it, this is going to get worse. But if you have an external fixator and you give some respect to the area where you had the first fracture, you can do a second lavage without that much difficulty if needed, and the patient might get a better care of that wound without having some metal on top of it. On treatment for type 2, we have to also always do a cervical lavage in any exposed fracture. Remember that these are orthopedic emergencies, okay? So they must go into the OR and get the lavage done with plenty of physiologic solution. That may be 2 liters, 3 liters of it. So you grab these bottles, they just pour it down and put it in. Some surgeons use microdiazine, or they use other antiseptic solutions. That's fine, as long as you just wash away everything that is in the wound. Then do the empiric antibiotics, but in second degrees we have to add aminoglycosides with the first cephalosporins, first generation cephalosporins. Okay, so what is this for? Well, this is for the gram negatives that might be there, and which are the most frequent gram negatives bacteria that you're gonna get in these kind of wounds? They're gonna be E. coli. Okay, so you want to have this broader protection for the patient. After the surgery, do the splinting. Also remember what we talked about, the external fixator that works for any kind of open fracture. Type 3A, okay, fractures that maybe they brought them from far away and it took over 8 hours for it to arrive to your service. So when you're doing the surgical lavage, you have to be very thorough. Then you might think about some kind of covering. If you don't have a good covering done by the skin of the patient, you're going to need maybe help from the plastic surgeon or later surgery by the plastic surgeon to get some skin coverage on top of it. Empiric antibiotics also are going to be 2 combination. You're going to have the first generation cephalosporins and the aminoglycosides. This can be gentamicin, or you can also use amikacin. Any of those just work perfectly well. Remember that you're going to have a culture taken during the surgical lavage. You're going to take 3 samples, okay? One of these samples is going to be from the gram test. You can have the gram test done in just 15 minutes. It's just putting a drop of Chinese ink into the sample and looking on the microscope. You're going to see the gram positive cocci or the gram negatives. You just get to see them right there. You don't know if they're going to belong to any specific family, but at least you know that something's there. Okay, so gram is mandatory. And the second thing is you're going to send a tube of samples so that you can have them grow in the lab. And the last one, it's going to be cytochemical analysis, so that you may measure the different things that are happening in that wound, like the glucose levels on the serum. Okay, if you get low glucose levels on that wound, well, that might also help. Also, you want to know if there's any other kind of alteration. So 3 samples are good. Remember that the WIAT, the World Against the Infection in Traumatology, said that we must always get 5 samples so that we may get a good culture, because from every 3 samples you're going to get 2 negative and 1 positive to grow in any lesion that shows infection. Okay, splinting and your external fixator. So these are the bullets with 22 caliber. You can see that they get stuck in the ballistic gel. So you can see the cones, the sound cones they make when they go in. They are smaller than this next sample. This is a 38. You can see it goes all the way through, but if we put it in slow motion, you're gonna see that the sound makes this big expansion, and it's air pulling in and opening and damaging. Okay. Type 3, 3B. Okay, so these are the polluted or contaminated wounds. So also cervical lavage, you have to be very thorough. But we're gonna make a triple combination of antibiotics. First generation cephalosporins and aminoglycosides, and also metronidazole. Metronidazole is gonna help to get rid of amoeba or parasites that might be on the water or the sand or whatever you got on that wound. Okay, splinting and external fixator. So type 3C. Okay, we're gonna have these is different from the polluted one, but we take care of it as it is polluted. These are like really bad fractures because you have neurovascular damage on top of them. It doesn't matter if it's big or small. It could be a finger, okay? But if you have neurovascular damage, then you must do your MAS category, the mangled extremity severity score, so that if you get a 7 or more on that score, you're gonna have to do an amputation of this member, okay? Here we have the different high-speed bullets that they're used mainly by the army. Okay, so if you have these rifles that shoot 45 calibers or something close to the 50 caliber, or all the way to the Barrett. This is a Barrett gun, 50 caliber. Most of the army trucks use this kind of gun, or ships. So only one bullet, you can see the ballistic gel. These are two ballistic gels, one after the other, and they both just blur out of the picture. They just are torn apart by the bullet. So if this goes into a human being, the sound expansion is almost 4 feet wide. So that's a lot. That's 1 meter, and it just patients just explode. Their legs come off, their arms come off. So you're gonna have neurovascular damage. That's why I told you that it's almost impossible to have a shot by this and no vascular damage. This happens when it goes to the head. This is a plastic head and it just blows away. It just disappears. So the patient arrives like this. You're gonna look at a leg or an arm. They just you have to worry about where you're gonna do the amputation more than if this can be reversible. It usually is not. So the mangled extremity severity score, you're gonna have to do this score first thinking about the skeletal and soft tissue injuries. So we're gonna talk about low energy, that means a fall from your own height. Medium energy, that might be open or multiple fractures, dislocations. High energy, it's a high speed MVA or a rifle gunshot wound, as we just saw, or very high energy, high speed trauma, or gross contamination on top of it. How fast is high speed trauma? We're not talking about bullets anymore. We're going to talk about a patient. If he goes on a vehicle that it's going over 80 miles per hour, it's very high energy. Okay, if it goes at 30 miles per hour, then we're talking about medium energy. Okay, if we talk about a patient that is stabbed, just falls off the stairs, it's not that bad. Okay, unless he falls from a whole flight of stairs. If he only falls from one stair, it's okay. But I don't want to get too picky about that. Limb ischemia, that means that when you do the capillary test, the capillary feeling test on the fingers, you're gonna see that if it's automatic, there's only a little pulse reduction, then it's first degree. Pulseless, with paresthesias, diminished capillary refill, that's you give it a 2. Cold and paralyzed limb with no sensation or numb, then you give it a 3. Okay, the patient is in shock, so you have a 0 when the BP is on top of 90. Hypertensive transient, if you see that the patient just drops its blood pressure and then it comes back, well, then you have it. Persistent hypertension, the patient's not recovering even with given solutions in emergency room, well, then you have to put a bigger grade on top of that. The age, young people heal better than old people, so same thing. 0, 1, and 2. If the score is over 6, that means 7 or higher, then you must do an amputation for this patient. So that's about it. This is a video about open fractures. I hope you liked it. I hope it helps you with your practice. If you have any comments or questions, please write them right there. Please help us with a like and subscribe to the channel. Follow us for more videos about orthopedic surgery. So I hope you liked it, and I'll see you on the next one.